right, hi everyone. It's the top of the hour, so we're going to go ahead and get today's session started. Thanks so much for coming to the Evidence Pyramid Problem. My name's Erica Lake, and I'll be your host today. I'm the Health Sciences Librarians Outreach Specialist for Region 6 of the network of the National Library of Medicine. Region 6 is based out of the Hardin Library for the Health Sciences at the University of Iowa. All right, so we are trying something a little different today. We have set this session up as a meeting instead of a webinar so that we can have a live discussion after our speakers finish their presentation. We ask that everyone please follow basic meeting etiquette and stay muted during the presentation to limit background noise. You are welcome to post your questions and comments at any time during the session. Please use the chat function to share your comments and use the Q&A function to submit any questions you have for our speakers. Miles Dietz Castell, who is Region 6's communication specialist, is providing production assistance. He's taking care of all the technology today, and he's going to be helping me keep an eye on all your posts. We are going to queue up your questions as they come in and save them for our speakers to address at the end of their presentation. We have a lot of folks attending today, but we are going to do our best to keep things running smoothly so that we can maximize our time for questions and dialogue. As a reminder, by registering for this session, all attendees have agreed to abide by the NNLM Code of Conduct to foster a respectful and professional learning environment. All right, just a few additional items to cover. We do have a live closed captioner with us today, and closed caption is available by clicking on the icon with the three dots at the bottom of your screen and then selecting captions. We are recording today's presentation and we will post it on NNLM's YouTube channel in 1 to 2 weeks. At that time, everyone who registered for this session will receive an email from us with a link for the recording, so keep an eye out for that. This webinar is eligible for Medical Library Association continuing education credit and continuing nursing education credit. You'll be able to claim those through the evaluation link that we share with you at the end of the session. And speaking of that evaluation, your feedback really matters and it helps us improve future training. So please take a moment to complete that. Since some of you might be first-time attendees to one of our webinars, I'd like to share just a few words about who we are. NLM, the National Library of Medicine, is one of the 27 institutes and offices of the National Institutes of Health. It's the world's largest biomedical library and produces online resources like PubMed and Medline Plus. NNLM, the network of the National Library of Medicine, is an outreach program of NLM, providing education, engagement, and funding opportunities for health information. NNLM is made up of 7 regional medical libraries, 3 national offices, and 4 national centers that connect with our 9,000 NNLM member organizations. If you'd like to connect with your regional medical library or learn how to become a network member, you can check out our website at nnlm.gov. Today's session was organized by Region 6 as part of our Speaker Spotlight webinar series. This series features expert guest speakers presenting on topics of interest to all of our users, which include librarians, public health practitioners, educators, clinicians, and others who work with health information. These webinars are scheduled intermittently throughout the year, and you can learn about upcoming sessions by checking out the NNLM training calendar or by following your regional medical library's newsletters, blog, and social media posts. All right, so it's my great pleasure to have our 3 speakers with us today. They're going to be introducing themselves in just a moment during their presentation. So without further ado, I'm going to turn off my camera and turn the reins over to them so they can get started. Welcome.
I'm going to get things started, and the title of our presentation is The Evidence Pyramid Problem. We do have an introduction slide here, so I'm going to actually advance and tell you maybe a little bit about myself first. I'm Jen DeBerg. I also go by Jennifer. And then Laura and Stephanie will also speak a little bit about what they do. But I am a health sciences librarian at the University of Iowa Libraries. I'm at the health sciences library at the Hardin Library. We serve all the health colleges here at the University of Iowa, and I am a user services librarian, which means that I oversee assessment of our services, and I also get to work with the College of Nursing and the Nursing Services Department at the hospital, so I get to work with Laura regularly. I also get to work with some other departments. I'm also a liaison librarian. So I'm going to turn it over to Stephanie to introduce herself next.
Good afternoon, everyone. Thanks for joining. I'm Stephanie Edmonds. I am the nurse scientist at Abbott Northwestern Hospital, which is part of Allina Health in Minneapolis. I was previously the nurse scientist at the University of Iowa Healthcare, worked with Laura Cullinan, Jen DeBerg, so do a lot of clinical research in the hospital and evidence-based practice as well. And I'll turn it over to Laura.
Thank you, Jen and Stephanie. It's great to be here, and I'm really excited to get to talk with you and learn from you and learn from your questions as well. I'm an EVP scientist at University of Iowa Healthcare on the clinical side in the Department of Nursing, and do some research, but really focus on leading evidence-based practice, and have been doing that for a while, and just continuously see what the needs are of the clinicians and trying to figure out how we can use the science to be really actionable to meet those needs. So excited to get started here, and I'm turning it back to Jen.
Okay. All right. So we need to know a little bit about our audience because we don't know a whole lot. So we have a poll that we're going to go ahead and launch now. And I think I can probably stop sharing for a moment and launch the poll. Filling this out. Are you seeing this, Laura and everybody? Okay. Okay. I wasn't sure if it was actually displaying, so I was a little confused about that. Okay, so we have some others. If you're interested in letting us know in the chat, I didn't, have a lot of other categories here, but if you'd like to participate in the chat and let us know who you are, that would be great. We have a lot of health sciences, probably a lot of health sciences librarians, some clinicians, but mostly it looks like a lot of librarians. 5% other. All right, so I'm going to end the poll. And I believe I'm just going to, I could share the results. I'm not sure if everybody can see the results. Maybe
we can
that
see
works. Okay, now we're good. Okay, so now I'm going to stop sharing. And we do have, I think, one more poll, but actually two more polls. But we'll go back to the slides here for a moment, get back into those, make sure I go in the correct order of things here. So the next slide is all about what we're talking about today. So we were asked as authors of this paper to talk a bit about the paper that we wrote, and it was kind of thought that we might be doing kind of almost like a journal club with the authors kind of guiding, facilitating, but we have a lot of people here, so we don't expect this to be like a typical journal club, that's for sure. It's a very short read, so if you haven't had a chance to read it, that's totally fine. You can definitely take a look at it later. I just wanted to mention a couple things about the article. It is part of a series in the Journal of Peri-Anesthesia Nursing, and Laura actually heads up the column about evidence-based practice, and they've dealt with a lot of other issues in evidence-based practice, such as PICO and how there are problems with PICO and how that works, as well as implementation failure, team science, and some other things that are coming up. And she will probably go into that a little bit. But want to mention that it's kind of a persuasive article. It's only a few pages, so you definitely can get through it. We're going to be talking about quite a bit of it, but I want to just call out a couple of points of the article. And the first one is that the article kind of goes into really how practice change, what are the criteria for practice change to be successful. That's kind of it really covered well in the first part of the article. And then in the next part, there's a bit of detail about how the evidence pyramid, there's more opposition, growing opposition to using the evidence pyramid exclusively, and evidence grading schemes in general as well. But nursing is a little bit behind the curve there. And I would argue that health sciences librarianship is also behind. So that's important. We're going to talk, actually, Stephanie's going to talk a lot about how simplifying the appraisal of evidence has a lot of negative effects. And then Laura is going to detail, which is also a large section of this article, about whether there might be an alternative solution and using the evidence funnel. And she's going to go into detail about how that might work. And then I'll also just call out that at the end of this article, I have a case example from my practice in health sciences librarianship that was actually a real case. So that's a little bit about the article, and we do have a reference list at the end of our slides too. So if you're interested in reading some of the other articles in this series, they're included in that list. I might have missed a poll. No, I didn't. Okay. So, all right. So evidence pyramid, as we know it, we think it's early 2000s when that became more popular. Evidence grading systems were gaining a lot of popularity in the early 2000s. And I read that around 2002, there were over 100 evidence grading systems available for use, which is kind of mind-boggling. The evidence pyramid became a standard in EBP education. I think pretty much all disciplines really have relied on the evidence pyramid, at least to my knowledge. And it definitely seems like it's still in use quite a bit, although I think that it's losing some traction with educators, especially in medicine, where they're really more endorsing grade now. I mean, it's kind of indicating that they maybe feel that the evidence pyramid is not sufficient. But there's a lot of acceptance because, it's easy to use, right? It's an easy thing to use. And of course, when you teach a student to use the evidence pyramid as a method to simplify a very complex landscape that is evidence-based practice, it becomes hard for them to not use it. It becomes very ingrained. There are a lot of criticisms in the literature. I just want to mention too, we're not the only ones criticizing the evidence pyramid. There's a lot of literature about this that's also in the reference list at the end of our slides. I wanted just to mention here that I do have a little bit of a story to tell, that I worked in healthcare for 15 years before I became a librarian. I worked as an occupational therapist, and I was exposed to the evidence pyramid when I worked as an OT. And I was really attracted to it because I thought, well, what an easy way to help me focus on the strongest evidence and the most powerful evidence. And I should have known better because the evidence in occupational therapy is kind of limited, but I really didn't. So I really liked the evidence pyramid in the beginning. And then when I became a librarian, my first few years as a health sciences librarian, I was teaching it regularly to family medicine residents as well as nursing grad students. And, nobody ever questioned it. It was pretty well accepted. And it wasn't until I began having some trouble with the PICO not working well, especially with the family medicine residents, but nursing students as well, people having very complex questions, that it really did not work. PICO did not really work, that I started to question whether the evidence pyramid was really working well either. And honestly, I was teaching in the Advanced Evidence Institute, which is offered by Iowa Healthcare, and Laura is the leader in that. And she kind of diplomatically asked me, as she has a good way of doing, as to whether I might think about modifying that pyramid slide a little bit. And, I kind of went back and thought about it, and I cut it out of my slides, and I cut it out of all of my slides, and I don't miss it at all. And so I just wanted to share that anecdote. I'm not to the point where I completely have incorporated the evidence funnel yet. But I'm getting there. So this slide has a little bit of detail about some of the variations on the evidence pyramid. I just had a little fun with, finding evidence pyramid images here. The one on the left is, I think, the origin of the evidence pyramid. And then the second one over is the Cochrane version. The very, very colorful one that you probably can't read any of the text on is somewhat of an upgrade, I think, because there's acknowledgement that non-randomized studies fit in to the pyramid, which is nice. Far right is one I just discovered, and this one actually incorporates AI tools into the evidence pyramid, which I'm not really going to talk about today, but I thought it was interesting, so I went ahead and threw that on there. there's a lot more out there, as you know. Some of them put meta-analysis at the top, some put meta-analysis and systematic reviews together. There's a lot of variations out there and a lot of colors. But those are a couple that I thought were interesting to look at. So we have a couple more polls here about how often you use the evidence pyramid in your work, and then do you believe that the use of the evidence pyramid causes any problems with evidence-based practice? Wow, we're getting kind of an even mix here. This is actually very interesting and not what I expected. I actually thought more people would be using it often, so this is interesting. Did I already share? I don't know if I shared. Sharing, yes. Okay, good. All right. So we're going to go and do one more poll. A lot of unsures. Very good. Thank you very much for participating in this, in the polls. We really appreciate that, giving us a little bit of background about how you're using the evidence pyramid. And we're going to turn this over to, I believe, Stephanie is next.
Yeah, thank you, Jen. So I wanted to start off by just kind of giving you all some context to where we are coming from and what we do every day, and why we have been sort of struggling in our everyday practices with the evidence pyramid. So this is the Iowa model of evidence-based practice. It has been around for over 20 years. And I can't remember the exact date, Laura, I think 2000 something. I'm going to get the exact date wrong, but the most revised version is here. It was revised in 2017. And obviously it's difficult to read the small picture there, but it's really a step-by-step process of evidence-based practice. So taking nurses or other clinicians through how to change practice. So how to identify the issues or opportunities, the triggering issues, to formulating that purpose, to determining if it's a priority, to forming your team. And then next is really where we're focusing on, and that's the piece that's highlighted, assembling, appraising, and synthesizing the body of evidence. And because it's evidence-based practice, that step is incredibly important. So we, will always start off with conducting the systematic search through the evidence, and then we'll weigh the quality, quantity, and consistency and the risk associated with the evidence when we're thinking about what do we need to do to change our practice. And this is when we really involve our wonderful librarians like you all, like Jen. So I wanted to set that context first. You can go to the next slide. So Jen already showed so many different versions of the evidence pyramid. This is just kind of an overview that we created for our article, really a summary of all of them. So obviously they can be a little bit different depending on which one you use or like. But generally, they're putting the systematic review or the meta-analyses up at the top, followed by the randomized controlled trial. So, that's kind of the gold standard. If you're going to just look at one research design, that's considered the best, the gold standard research design. And then followed by cohort studies, case control studies, descriptive research, qualitative research. Sometimes you'll see those on the same level. Animal research, I've seen, some pyramids don't have those. Animal research, and then expert opinion. And like Jen said, the evidence pyramid was likely established around 2000. It really places the research designs that have more internal validity. And if we remember, Internal validity is generally those that have like less systemic biases, like that can determine like that cause and effect, that control for confounding at the top. So randomized controlled trials, because they're randomized, have more internal validity. So now, like Jen has showed, they vary a little bit. There was one other one that I didn't include the picture of this. I think it was in 2016 from like Murad, I think was the first author, where they took that top triangle, and they like made it into the handle of a magnifying glass, and then they like put the magnifying glass over the single studies. That was like kind of the most recent change I've seen. And then they use like straight lines to reflect that grade approach that we were talking about earlier. So if you want to go to the next slide, Jen. So I want to talk about some of the assumptions that are made with the evidence pyramid. So the first one is, I think, we can assume that the evidence pyramid was really this attempt to manage our clinical emphasis or overemphasis on expert opinion as the driver of healthcare decision. So I think, a lot of the times before we really, value this randomized control trials and research in general, a physician or a clinician would say, oh, in my expert opinion, this is what I've seen, and then this is what I think would work. Well, obviously, yes, a randomized controlled trial showing cause and effect is definitely the best if you're doing like a pharmaceutical or some type of intervention like that. So I think that, the attempt was to really manage that expert opinion, and by giving this hierarchy of evidence. So that's when that internal validity really is like driving and assuming that that's the most important thing, is that cause and effect. And so assuming that the certain types of evidence are the most important and the most valid and reliable. So this is assuming that meta-analyses and randomized control trials are the most valid and most reliable types of evidence. And now I think we're kind of learning along the way that that is not always the case. And then it's also assuming that studies with larger samples are better. So a randomized controlled trial, often they'll have larger sample sizes than a qualitative study, for instance. Or a meta-analysis will definitely have a larger sample size than a randomized controlled trial in a lot of cases. So they're making these assumptions that that's always the better, so we're going to put them up higher on that level of evidence. It also assumes that evidence that is intervention driven is a higher level. So randomized control trials are really good for determining if an intervention works or not. Like I said, like pharmaceuticals. But then it misses this picture of, is the diagnosis accurate? Is the assessment accurate? And then all these other issues that go into healthcare. And then it also assumes that quantitative evidence exceeds qualitative evidence. So it's better than qualitative evidence. I also want to mention that, and I liked how I wasn't planning to share it like this, but I'm going to, because Jen shared her kind of personal experiences with evidence pyramids. But I wanted to share that nursing studies are rarely ever randomized controlled trials. Usually just due to like feasibility, and ethics, they really can't be randomized. So that means that nursing research, which is highly valuable to patients and the care that we provide, would never be considered a higher level on that pyramid. And I say that because one time I did have to go through, when I was getting my PhD, I did a concept analysis on a topic that really didn't have a lot of research about it. And so he was doing an abstract for a national nursing conference, and so that's, like a systematic literature review. And so that's how I submitted the abstract, and they wanted me to, list out each study and then put the level of evidence. And all of the evidence that I had was like a 4 or 5 level, like the worst levels. And so it feels really defeating, I think, when you're a researcher, when all like the research that you're reading or conducting is in that lower levels of evidence, even though it's like super rigorous and important. I think just assigning that value to it is kind of defeating. All right, next slide, please. So there's, in addition to these assumptions, then there's these biases that are introduced by this pyramid. So like I said, when you have these higher level of evidence, the clinicians are going to go towards those. They're going to value those higher. So the clinicians may not even go to those lower level types of evidence. They may say, oh, there's like tons of randomized control trials or case control. So I'm not even going to read these qualitative research because those are lower level and we have so much of the higher level. So we're just going to move on. And then as we all, I think, are really realizing and hearing a lot about, randomized control trials are not applicable to clinical practice always. It's really limited to those individual patients, the generalizability. And as my third bullet point says that it's also the findings of these randomized controlled trials are not always applicable to minority groups because those patients are generally unrepresented in those clinical trials. And then finally, qualitative studies are placed lowest on the pyramid usually, but they are often the most helpful for gaining patient and clinician perspective and values, which is one of the 3 main, we would call them legs of the stool of evidence-based practice. So evidence-based practice, the evidence, patient values and preferences, and clinical judgment. So if we don't incorporate our patients' values or really our clinicians' values and perspectives, and whatever practice change we're implementing is not going to work. So the evidence is only part of that picture. Next slide. So what do we actually need from the evidence? So Tibler, who is one of the creators of the Iowa model, defined best evidence in 2008 as empirical evidence from randomized control trials, but also evidence from other scientific methods, such as descriptive and qualitative research, as well as use of information from case reports, scientific principles, and expert opinion. Which that definition really incorporates all levels of evidence. The one thing that is missing, we feel, is the type of evidence is that quality improvement data, which really brings in the local context. So the quality improvement data from your local hospital or clinical setting. Next slide. So finally, I just want to reiterate, part of this, the reality of how we apply best evidence. Healthcare obviously is so complex, and a randomized control trial or some of these, other higher levels of evidence are not just this simple reality. Clinical reality isn't like, just this like a randomized control trial where everything is neatly controlled. We have changing practice patterns. We have processes of care that are cognitive and physical, and they also incorporate our social and behavioral norms and values and roles. It also incorporates the organizational, our system, our teams, the tools and technologies that are available to us, our facilities, like how they're laid out, how we can access our equipment, and then the tasks that we need to do. And then all that kind of goes into, how we care for our patients, and then ultimately the outcome. So there's just increasing pressure to achieve these variety of outcomes on our regulatory or our accreditation agencies, or for reimbursement from like Medicare, Medicaid. And our patients are becoming increasingly medically complex. They have more comorbidities. And a lot of the times in these like randomized control trials, they'll control for all of that. So we don't understand how those comorbidities work together. So we just have to think about how change happens over time, and it's, in this like very complex context. So we need to think about how to use evidence in this very complex system without, this like very hierarchical categories, if that makes sense. So with that, I'll give it over to Laura.
Thanks, Jen. Stephanie, appreciate that. Working through the animation there. Okay. So what I get to talk about is, what are we doing with our evidence? And I think we want to really think carefully about what is the intent when we are trying to find and synthesize evidence. When we're trying to do conduct of research, what we're really looking for is a hole or a gap in the evidence, and clearly defining it so that we can do research that will address it. With evidence-based practice, we're actually trying to find the best evidence possible to fill the gap. And so very different foci when we all are sitting down to look at what might be the very same evidence. Go ahead and advance, Jen. So with evidence appraisal, what has already been shared is that the pyramid is really quite rigid, and it doesn't balance what we need when we're looking at that body of evidence. That gives us a whole bunch of rich information that will help us downstream when we're working through the evidence-based practice process. And so what we think of this is really, it's like missing the forest for the trees. We're so focused on grading an individual study, which is really just a repeat and a restatement of the research design. So by looking so closely at the individual trees, we miss the whole forest. And with evidence-based practice, it's really important that we catch that forest. So please advance, Jen. What we've proposed that we want to do is build our understanding from the best evidence systematically, step by step. And in doing this, we will start with first understanding the background information and the background details, just to give us a little bit of a broader understanding, and also to pick up some of those terms that are used in the literature that might help us when we're looking downstream for that evidence a little bit more carefully. Looking at the prevalence and severity gives us a sense of the magnitude of the problem, as well as wanting to understand what are the characteristics of a patient that put them at risks or creates risk factors. Those details will help us identify the patients that are most likely to benefit from an evidence-based practice change. And then we can move on to really focusing on how can we engage those patients and address their patient experience and their values so that we can include that information. So we shifted from those cohort designs into that qualitative, research design at this point before we move on to how do we assess the problem and do that correctly. And all of this then helps us then better understand how should we intervene. And that information, then we want to do a step back and think, well, what is the state of the science more broadly to make sure that we've captured what we need, because we're going to have to do troubleshooting as we're designing the practice change and figuring out how to implement the change. These then help us understand what are the outcomes, again, stepping back and doing a double check, and what are the unintended consequences, because that will impact our evaluation as well as our design of our practice change. All of those are really critically important. So the next step, what we called phase 2 in the article, is taking this pyramid that I liked including animal research in the pyramid because I've done evidence-based practice work that really had to rely on animal research as well, even a lower level of evidence. So we're flipping that pyramid and turning it upside down, and now we're creating an evidence funnel. So the evidence funnel gives us rich information. Yes, we want to look at the quality of research studies, but we aren't stopping there, and we aren't stopping by just merely restating what the design of the research study was. And we want to go even beyond just research. We do want to look at quality. We also want to include the quantity and consistency of the body of evidence. So what I find is that even though you're listening for horse hooves, there's going to be a zebra out there. There is not going to be 100% consistency, and that's okay. It will give us important information about when things don't actually work. So quality, quantity, consistency, those are important. We've known that for a long time. Then looking at what is the strength of the recommendation from the body of evidence and the certainty of benefit, which helps us get into, is there enough evidence to think that this practice change recommendation actually will stay static? Or is the evidence weak enough that we still could anticipate a change in a recommendation? These were pulling from the U.S. Preventive Task Force services, and they parallel that grade system as well. But now we need to think about localizing. We have to get to a product that's going to help us fit our local needs, the needs of our local patients in our local setting, and then designing that practice change. So thinking of it more as sieves, working through this as a funnel, can help us get a long ways into what we need to actually create the practice changes. So go ahead, Jen. What I wanted to do next is actually get into, like, what are we doing with this information? We have to make a decision about whether or not there's sufficient evidence. We're balancing where there is strong evidence, where that evidence is still missing, or where there's information that may not be even coming from evidence. So, for instance, we might be interviewing our patients and using that information again to get to recommendations that can fit for those patients, but specifically the patient we have right in front of us as well. So when we're thinking about that, we have to think also about looking at the evidence, and I think of it as an onion. So Jen, if you want to go ahead to my onion. When we are looking at evidence, we're going to peel back layers and think about how we're going to get to the core components. Those core components are critical. They're essential for success for the practice change to work. But getting to those core components isn't always straightforward and easy to do. So we've got to peel back the layers, and getting to other designs will help us understand core components because they're giving us information addressing different questions. Through those different designs. We also want to think about engaging our patients. We've called this co-design, and we have a publication that's in press in this series about this. But here's where we want to collaborate with our patients early. And we have described how we can engage patients every step along the way in our book. So we want to be able to shift from doing 2 and 4 patients to doing with patients. And we do that by having them partner in the team as a team member all the way along in our evidence-based practice process. We also then want to think about that information from our engineering partners in user-centered design. because it's critical information to help us get to design that is usable, that's feasible, that's going to just get rid of the distractions, keep relevant information in the center and where it's easiest to see, and organized in a way that will help us as clinician users. We want to think carefully about resources that are available, whether it's the expertise, the equipment, the skills, the training. All of those resources are going to impact, because then we again need to tailor to that local setting. And then in that local setting, we want to think very specifically about the clinician practice patterns and workflow and integrate practice changes into those. So again, using evidence to help us get there is critically important. And the randomized controlled trial doesn't provide that information. We get that information from all those other types of research designs that help inform those subsequent decisions that are downstream, well past using that pyramid, that we find just isn't helpful. So if you want to go on, Jen, to a little bit deeper dive into those layers, the solutions we want to think about, I think of as layering from core components being critical to include. They help us with decision points that we need to make abundantly clear in treatment. Then that next layer out are those influential characteristics that impact our consequences and preferences. And then an additional layer further out that is even more adaptable, that are the resources addressing those intervening and convening and confounding variables as well. So we're going to use that evidence that we've built that knowledge step by step to address these when we're designing our practice change. But if you want to move ahead, Jen, we're also going to use that evidence that surrounds the core to help us figure out how to evaluate. We've proposed an evaluation framework we call KEBAB, and we have an implementation framework, the Iowa Implementation for Sustainability Framework, because again, we're going to use that evidence for what we're calling a precision implementation approach, well beyond the randomized control trials and systematic reviews and meta-analyses, to help us with these subsequent steps in the evidence-based practice process. So if you want to go ahead, we have the series that Jen introduced and Stephanie spoke about, a number of topics that we are addressing and have underway. Several are forthcoming in Journal of Peri-Anesthesia Nursing. So you can see some are published, some are in press, some are in review, and many we're hoping that are forthcoming. So we welcome you to be part of our EBP Revolutionist. And go ahead and advance one more time. We want evidence-based practice to be up to date, using the best evidence. And we have a number of resources that we can share, free tools that are available, make them welcome to you, and they're at our website that's listed there. And to help facilitate some discussion and Q&A, I'll turn it back to Jen for another poll.
Okay, so I'm not sure that we're going to do this one as a poll. And I'm not sure how we're going to do it at all. So we might just first see if there are questions that have come in. I might just check in with Erica or Miles to see if there are questions before we do this.
Yeah, Jen, we do have 5 questions in the Q&A there.
Given that we have 10 minutes, I think we should go to those questions.
Okay, do you want me to read those out, or we could have folks who submitted them unmute themselves and ask too, if
It might be easier for you to read them, Erica. Yeah, I think so.
All
Unless
right.
people are preferring to do that.
Okay, so the first one, there was a concern that the evidence that is, quote, best is also the evidence with the, quote, least research bias, and perhaps with the least constraining limitations. Do you know what research types are more likely or less likely to incorporate research bias, and more or less likely to make claims that are constrained by limitations?
Well, I'll start, and then I will kick it to the others. Okay. Unless Stephanie, do you want to go?
No, go ahead.
Well, I would say that the focus is dependent on the method being used, which is dependent on the question being asked. And so it's not that there's one design, it's doing the design you're doing well.
Yeah, that's definitely what I was going to say, Laura. We have an appraisal tool, and by we, I mean Iowa, in our evidence-based practice and action book to look at an individual study, and really, determine if is this the right method or design to answer the research question at hand. So that's really your first determination. But then, yeah, like even then, it's really the individual study itself to determine if whether or not like they're reducing bias as much as possible. Every research study has bias, and every research design has its own type of bias. Some of it, like I said, randomized controlled trials have maybe less internal valid or are more internally valid than a qualitative research study, but they don't have as much external validity often, like they're not as generalizable across different groups. So it's, and not necessarily qualitative research is either. So, it just really depends on, what is the research question? Are you choosing the right method? And then what are you doing to reduce the bias? So it's really based on the individual study and the quality and rigor of that study. I hope that answers the asker's question.
Well, the next question is pretty straightforward. They were just curious if all the references mentioned in the on the slides are mentioned in the paper.
I think not. I could be wrong though, Laura. Correct me.
Yeah.
I think that's correct. The papers, this series is written to be, it's definitely evidence-based, but it's written to be a fairly light read with space constraints. So not all of them are, but the literature is, I would say, fairly abundant.
And a lot of them are in the link that's at the end of the slides, but not all of them too. So it's kind of like a list of like related articles and a lot of the references. So, but yes, not all of them.
Okay,
And I think there's been a lot of requests for the slides, so that may help too. If we can share our slides, they can get all the references and
yes, we can definitely do that. When we send out the link for the recording to everyone who registered for this class, we'll also include the slides. We also had a question, would you consider currency as a stage of the funnel?
I can say probably not. I don't think so for most topics. I don't think so. I think it would depend on the topic. I'm sure Laura has a lot more to say about this, but I'm sure there are a lot of people in the group who are irritated by the 5-year rule. That's pretty common in nursing education, and yeah, so I'd say I don't think it would be a step in the funnel. What do you think, Laura?
Yeah, I agree. I think we have evidence of, and this is case studies, so it would be at the very bottom of the pyramid, thus the lack of helpfulness of the pyramid. But there are case reports where setting limits related to currency, often that famous 5-year rule, has led to patient deaths in clinical trials because case reports had occurred earlier and they were missed. So from a clinician perspective, setting limits that are artificial like that creates risk that is unnecessary. And it may be done to create an academic assignment and make it a little bit easier to do. But our clinical problems have been around forever. So the best evidence and timing for it depends on the issue you're trying to address.
Okay, our next question. What steps or tools do you use to determine certainty of evidence? Does it involve a matrix to help visualize methods and outcomes of studies being included?
Well, just for the sake of time, I'm going to refer you to the U.S. Preventive Task Force and their approach to grading. That'll give you their definition for certainty of evidence, their rating system for that, but recognize that all of this work is subjective. It's done by experts, but it is subjective. But I would refer you to the U.S. Preventive Task Force Services for that.
The evidence-based pyramid is used in undergraduate nursing textbooks. Are any other authors or nursing associations addressing the ideas of taking a different approach to the use of evidence-based practicing in nursing?
Not to our knowledge. However, I will say there was a recent publication from an EBP coordinator role. I don't know if that's her exact role at Johns Hopkins, kind of reiterating the same opinion about our article, like the applicability, practicality of the pyramid. And so we have been talking just very briefly, and it sounds like maybe Johns Hopkins is interested in looking at their approaches a bit differently as well. But maybe they're planning on publishing things next year, but we have not heard the details on that.
So I'll say we're cutting edge. I did put the article link that Stephanie referenced in the chat, if you're interested in that. There's definitely interest moving this direction. And I think, again, applying the science indicates we need to go this direction as well.
All right. We had somebody who stated they were one of the individuals that uses the evidence-based medicine pyramid in teaching often, but I always try to give caveats that it's not a one-size-fits-all structure. This information has been great, and I plan to use this in my teaching, but I'm curious to hear how you all teach evidence-based medicine without using the pyramid.
Well, I've just dropped it and talked about, really being more inclusive, but I do plan to try using the funnel more, but I haven't actually done a whole lot of that yet, but I do plan to try. I'm sure Laura and Stephanie both have ideas on this too.
Yeah, I really have dropped it, and I really focus on, if you remember in the slides Laura presented, the rainbow kind of steps, those 8 categories. So when I teach nurses about evidence-based practice and they're doing their evidence synthesis, that's where I'm having them go through each of those categories and putting their literature that they've found into those categories and making sure that all 8 of those categories have some evidence in them. So that's what I'm really having them focus on. And then when they're writing that synthesis, really looking at that funnel to make sure they're thinking of all of those pieces of the funnel.
Great. And then here's a little follow-up on the question we just had. Somebody said, what about a more generous rule of time period? Is research that is 40 years old as applicable as research published last year?
Depends on the topic. I will share that, okay, this is going to age me, but one of my early evidence-based practice changes that I was working with a post-op nurse on a surgical ward, and this was about 20 years ago. The evidence that we were looking for had not even been indexed yet in PubMed because it was so old. We went back, and the literature that was most relevant was from the 60s. And beyond that, the only thing relevant was in animal research. It completely depends on what it is that you're looking at and how extensively we have researched that topic more recently. I would argue that any artificial limit is going to potentially create challenges. Let the evidence be your guide.
That's all the questions that we had in the Q&A right now.
These are great questions, and I wish we could have a much more detailed discussion with you because you're clearly asking really critical questions and would love to hear your perspectives.
Yeah, thank you everybody for participating in the chat and asking all those questions. And I'm hoping we can maybe get a copy of the chat transcript too, so we can take a look at those later because it's so hard to keep up with. But it was great to hear from so many people. And we're right about at the end of time. But if somebody has one last question, I guess we could do that if somebody wanted to send something or unmute. Otherwise,
I had a question. I'm Marie Carter from VA Long Beach. And my question, and I always ask this whenever I teach EBP or effective searching, is no evidence itself?
Well, I think then the evidence needs to be broadened. There are times we will defer to scientific principles.
Or different population, or similar disease process. It obviously depends on the topic.
What can you relate? Like, how can you find something that's related and apply that? Yeah.
Well, thank you all for the wonderful questions.
Thank you everybody for attending today. I've been putting the evaluation link into the chat, and unfortunately it is not a clickable link. We weren't able to make that fly, but I hope that it's pretty simple enough to remember. nnlm.gov/feedback 10/24, so today's date. Really appreciate everyone coming, and definitely appreciate the three of you today for your presentation and the conversation that's been started. I did try to capture things in chat, so I'd be happy to share that with the presenters. I won't be de-identifying it and sharing that with everybody, but we will share the presenter slides and then the link for the recording. So thank you so much everyone for attending today.
Thanks for watching. This video was produced by the network of the National Library of Medicine. Select the circular channel icon to subscribe to our channel, or select a video thumbnail to watch another video from the channel.